Perfect. Good morning. You guys bring such a positive energy on this new week and new month. So thank you for having me here. Thanks to Dr. O'Keefe for the invitation to present on the long-term health effects of COVID-19. Clearly an evolving story, but I think a critical component to this pandemic. So the lay press has been covering this concept of long haulers, quoted here in the Atlantic as redefining COVID-19. Lay press has been covering this concept for several months, and more recently, our medical journals have been highlighting this clinical phenomenon. This was the viewpoint mentioned in JAMA, and I bring this up just to give special thanks to Carlos Del Rio at Emory and also Priti Milani in Michigan for the opportunity to start thinking this through and really put this out there as a call to action, bringing attention to practitioners that this will be ongoing among our patients, but also as a call to action for researchers to start investigating the science behind the symptom persistence and organ dysfunction that has really been observed by clinicians among patients that have, after COVID-19 illness. With that being said, the scope of the problem is really not well known at this point. There's no consensus definition of post-acute COVID-19, although as mentioned, the clinical phenomenon has been called, quote, long COVID, and affected individuals have been called long haulers. According to the COVID symptom study, whereby greater than 4 million people in the US, UK, and Sweden have contributed symptoms, it's estimated that approximately 10 to 15% of individuals with COVID-19 do not recover quickly, and that includes even individuals who only experience mild disease. There have recently been some proposed definitions put forth for post-acute COVID-19 being defined as symptomatology that's persistent beyond 3 weeks, and chronic COVID-19 as persistent symptoms beyond 12 weeks. And there's some scientific rationale behind this in considering kind of what is a reasonable time frame to define recovery from a viral illness, and then also taking into account that replication competent virus is not recovered beyond 10 days in mild to moderate COVID-19 and greater than 20 days in severe critical illness. And then finally, median duration of PCR positivity is around kind of this, pushing 3-week time frames. So hence some scientific rationale for proposed definitions, though clearly still needs to be sorted out. This was a recent publication in Open Forum ID, which again kind of highlights that while we have clear categorization of acute SARS-CoV-2, we're still working on post-acute COVID-19 definitions, and really the concept of persistent symptoms and organ dysfunction is probably one that's intertwined with a lot of overlap and remains completely not well understood. So starting with symptom persistence, I'm sure you guys are all very familiar with this study. This is kind of the initial description that was published in JAMA a few months back on persistent symptoms among hospitalized patients out of Italy, who were interviewed on the average of 60 days after symptom onset. And very interestingly, only 12.6% of patients reported no symptoms at that time period. Even more interestingly, the burden of symptomatology was quite high, with more than half reporting over 3 symptoms still persistent. And this was associated with nearly half of their cohort also endorsing worsened quality of life. Most common symptoms here seem to overlap with what you guys have observed with the data that Dr. O'Keefe just presented. And out of this study, most prevalent symptoms that persisted were fatigue, dyspnea, joint pain, and chest pain. A follow-up study out of France showed that the symptom persistence was not significantly different based on severity of illness, as a surrogate measure being, admission to wards only versus ICU level of care. And most frequent symptoms out of this study were fatigue, again, in over half of the cohort, dyspnea, and loss of memory. So a lingering question is, do symptoms persist among those with mild COVID-19, or rather a question of interest for which there are some preliminary data. This was an MMWR published at the end of summer, whereby a telephone survey conducted as a random sample among nearly 300 adults with positive SARS-CoV-2 PCR testing as an outpatient, which included ED setting, were interviewed at a median time post-symptom onset of 16 days, and 35% of 274 symptomatic respondents had not returned to their usual state of health. And this included 1 in 5 previously healthy young adults that, again, at 14 to 21 days after testing positive, were not back to baseline health, which is, I'm sure, as we would all agree, incredibly frightening. So moving toward specific organ dysfunction, we'll run through a couple of these quickly, as I know our time is limited. Cardiovascular sequelae is probably the organ system that has been best described to date. Acute manifestations are listed here. Honing in on the post-acute manifestations, what we're observing is myocardial inflammation and myocarditis with fibrosis and scar, potentially leading to arrhythmias, which have been documented, as well as reports of out-of-hospital cardiac arrest and sudden cardiac death. Reports of cardiomyopathy are also increasing, including stress-induced or Takotsubo cardiomyopathy. Just want to call your attention to this really nice review in Science about COVID-19 affecting the heart, with postulated direct and indirect effects on the myocardium. This was a study published in JAMA Cardiology, a German study of 100 patients whereby cardiac MRI was performed a median of 71 days after COVID-19 diagnosis, and cardiac involvement was documented in 78%, with ongoing myocardial inflammation in 60%. Importantly, the presence of chronic comorbidities, duration and severity of acute COVID-19, and time since original diagnosis did not correlate with findings. I do just want to highlight that this was a non-random sample, which likely biased toward cardiac findings. With that being said, here's another paper from JAMA Cardiology where, again, cardiac MRI was performed, this time among healthy competitive college athletes who were diagnosed kind of on the routine screening for COVID-19 by PCR. None were hospitalized and the majority did not report symptoms, yet 46% had evidence of myocarditis or prior myocardial injury by cardiac MRI. And this was performed anywhere from 12 to 53 days after symptom onset, after testing results, excuse me. So suffice it to say that persistent cardiac abnormalities have been identified not only in the elderly with multimorbidity, but also among healthy young athletes and have been reported among young healthy individuals, as we saw in the telephone survey reported in the MMWR. So moving quickly through some other organs, including pulmonary sequelae, this really focuses in terms of post-acute manifestations on signs and symptoms related to restrictive lung disease and after hospital discharge. PFTs measured, 30 days out, 3 months out, have been shown to be decreased in terms of the DLCO metric, and also nearly half of individuals have shown evidence of diminished respiratory muscle strength, and up to 71% of post-symptom, post-acute COVID-19 radiography has shown evidence of interstitial thickening and fibrosis. So if compounded on cardiovascular comorbidity, I think persistent decline in pulmonary function could have really significant consequences for our patients. Neurologic sequelae are numerous, both in the acute period, but also post-acute manifestations are kind of what we see acutely in terms of headache, vertigo, paresthesias, weakness, loss of taste, loss of smell, also encephalitis, seizures, and strokes, as well as Guillain-Barré syndrome. In addition, in the post-acute period, major mood swings have been reported, as well as brain fog. And so this is a nice paper out of Lancet Neurology that just tries to tie together timing of diagnostics, clinical presentation, and neuropathogenesis without much insight into what we're observing beyond 4 weeks. So additional characterization is needed. And finally, renal sequelae acutely mostly involves AKI with hematuria and proteinuria and portends a higher risk of COVID-19 mortality. There's also been reports of a collapsing FSGS or COVAN, standing for COVID-associated nephropathy. In the post-acute period, what we're seeing is prolonged kidney dysfunction with nearly a third of patients who required RRT remaining on dialysis at hospital discharge, and 37% of patients who didn't require RRT continuing to have kidney dysfunction. So I just want to make one plug for post-acute infectious inflammatory syndrome, or MISA, A being for adults, as this was initially described in children, but something, although rare, to be on the lookout for. In tying this all together, I think it's important for us as clinicians and scientists to start thinking if there's a common pathophysiology that's driving this shared multi-organ injury. There have been some postulations, including direct cytotoxic effect, potential dysregulation of the RAS system, endothelial cell damage and thromboinflammation, as well as overall dysregulated immune response leading to cytokine release syndrome. So many potential areas of study to look into further. And then finally, emotional and behavioral concerns, I think, are of paramount importance in this pandemic, and especially among those who are experiencing long-term health consequences of COVID-19. Just a couple of points on this. The diagnosis of COVID-19 and subsequent need for physical distancing has been associated with feelings of isolation and loneliness, as I'm sure you guys have all seen in the clinic. COVID-19 related stigma has become pervasive and can result in a sense of hopelessness. Increasing reports of lingering malaise and exhaustion akin to chronic fatigue syndrome may leave patients with physical debility and emotional disturbance, and individuals recovering from COVID-19 may be at even greater risk compared with the general population of depression, anxiety, PTSD, and substance disorder. I do want to make one point that there is precedent for this persistence, both in terms of a generalized post-ICU syndrome that has been well described in the literature, kind of independent of any pandemic, involving persistent cognitive dysfunction, acquired weakness, fatigue, dyspnea, also PTSD. And then in the context of pandemic, and specifically with this viral agent, both SARS-CoV-1 and MERS have had significant symptom persistence and organ dysfunction that has been reported in the literature, including reduced DLCO at 12 months and up to a third of patients having persistent depression, anxiety, and PTSD. So where SARS-CoV-2 will end on this landscape is to be determined. So in conclusion, I think where we're at is that this phenomenon is being recognized and that more data are needed. Longer ranging longitudinal observational studies and clinical trials will be critical to elucidate the health consequences attributable to COVID-19 and how these may compare with other serious illnesses. And granted, no long-term data are available at this time in terms of substantial numbers of patients, it's possible that large numbers of patients will experience long-term sequelae. I think it's important to recognize in the clinic and validate among our patients. And outpatient post-COVID clinics are opening as in many localities where large outbreaks have occurred to care for, again, what has been termed long haulers. And it's imperative that the care of this vulnerable population take a multidisciplinary approach with a thoughtfully integrated research agenda so that we can avoid any health system fragmentation and also allow for comprehensive study of long-term health consequences of COVID-19 on multiple organ systems, as well as overall health and well-being. And then furthermore, and finally, such an approach will provide the opportunity to efficiently and systematically conduct studies of therapeutic interventions to mitigate adverse physical and mental health effects among hundreds of thousands, if not millions of people who are recovering from COVID-19. So with that, I just want to thank all of you for what you're doing truly on the front line caring for these individuals as Emory Primary Care. And, behind every face, there's a family with this struggle. And, it's not just a case count. So thank you guys for taking care of these patients and being a part of this effort to mitigate the long-term health risks of COVID-19. With that, I thank you for your attention this morning and again for this opportunity to be with you guys, and I'm happy to take any questions.
Thank you, Dr. Collins. I'll open it up. If anyone has any questions you want to put in the chat or come off mute.
Hey, Dr. Collins, Ted Johnson here, and thanks so much for that update. It was really both thorough and a good overview, as well as getting us into some details about specific symptoms. I might be the only one who heard long haulers and thought of truckers, and I'm just wondering how we message this to patients who are worried about do they need their third and fourth and fifth nasopharyngeal PCR swab. They had COVID, they have symptoms. I think that many people wonder, do they still have COVID? And you gave us some information about that. What's the best language to frame this conversation up for patients with persistent symptoms?
That's a really good question. And I think a lot of us in the medical community, as you are, I think, alluding to, are not necessarily in support of this terminology of long haulers. It's actually come up several times that there, is association with truck drivers for whatever implication that may have. But I do think that it is a really good point you make in terms of the language that we use around this clinical phenomenon. And I think it's to be determined, although we need to be cautious, because I think already individuals who have had COVID-19, whether they have symptom persistence and longer term organ dysfunction, I think experience stigma. And now, with long-term sequelae, adding on to that, I think can be riskier for even more stigma and potential, loneliness, I think, as this is not yet fully described. So I think that it's one of the reasons that there's a major push right now to come up with a clear consensus definition so that we can, I don't necessarily want to say put patients into a box, but appropriately identify those that meet clinical criteria for this clinical phenomenon. And probably phenomenon even should be called condition and things like that. And so I think it's a really good point that you make, especially as some of the symptoms that persist are, fatigue and shortness of breath, and others that may, brain fog, that may not necessarily be able to have, objective, assessments at the ready. And so I think that it's certainly an area of ongoing research, and I think that including the terminology that we use is going to be critical moving forward.
Thanks so much. Any last questions that come up before we sign off? Dr. Collins, thanks so much for making your morning an earlier start and joining us. We appreciate your time. Thanks, everybody. Let's have a great Monday and a good week this week. Take care.